Thank you.
Fabulous. So listen, let's crack on. Really looking forward to today. Brenda's our first moderator, so hoping Brenda's there. So Brenda, can I let you take us away? I think Wanjiku is breaking the rules slightly and making a last-minute change. So good luck with that, and good luck with the meeting.
So, good morning, good afternoon, all. Thank you very much for making it for the meeting. So I will be moderating the first session. That will be the PhD's presentation. And sorry, Kevin, did you say something about Wanjiku?
Yeah, I think she was breaking the rules. Was
so we started.
Present herself, but it may be most efficient to crack on with what we've got.
Okay.
Okay.
So I'll put out the slide now.
Yeah. So I think. Sorry, I think I'm not sure about what the communication is, but Wanjiku, do you want to go first, or did you want Irene to?
I'm happy to go first. And
okay, fine.
Yes,
please start. Welcome, Wanjiku Kagima from Kenya, one of the brilliant PhD students. Karibu.
Do you want me to share my screen, or we just crack on with what I have?
So, Samuel, is that?
Yeah, I can take this off now.
Okay.
I will stop sharing. Wanjiku, if you want to share your documents.
Can you see?
No, not yet.
Not yet.
Okay, sorry. I think I'm wasting time. Let's just crack on. Honestly, I seem to have. I'm wasting time. If you cannot see.
Okay.
Yeah.
Can you see this? Yeah.
Yes, I can see that. My topic was on my PhD was on the utility of clinician-performed cardiopulmonary ultrasound assessment of the acutely breathless patients, and we called it the Breathlessness Early Detection with Ultrasound Study. So what new knowledge and insight does our research bring? I'd like to point out two important things. That there is a radiology and a diagnostic gap within the low and middle income setting, and point of care ultrasound has the potential to fill these two gaps in the diagnosis of majority of the causes of breathlessness. When we talk about the potential of the point of care, the basic forms of imaging which we have in low and middle income, that's ultrasound and chest radiograph, can actually address majority of the causes, and that's what was found in our study. And these two modalities not only diagnose the disease, but they have an impact on the clinical management and the patient outcomes in a low resource setting. Point of care ultrasound also brings the ultrasound to the patient. Therefore, it brings speed, but it requires well-maintained, accessible ultrasound equipment, and the providers must receive appropriate training and understand the advantages and also the limitations of point of care ultrasound to ensure the patient is safe. So what are the new evidence-based policy recommendations that our research leads to? With regards to the radiology gap, the imaging needs in low and middle income, as I've already said, can be addressed by a combination of the X-ray and the focus. And we also know that the POCUS is can come to the patient. However, we need more research to better understand the applicability and the feasibility of POCUS application. We need optimal scope. We need to know the optimal scope of ultrasound examination.
Sorry to interrupt briefly. Can I just ask Sam to move your slides along as you're talking, and then just if everyone, as they're giving presentations, just nudges Sam to advance the slides when they need to. Thank you.
Thank you.
Are we okay now?
Yeah, we're on the second slide.
Yes, the second slide. The evidence-based policy. So I was talking about the radiology gap, which can be addressed by POCUS. However, we need to understand the applicability and the feasibility of POCUS application. We need to understand the optimal scope of ultrasound examination, the diagnostic benefits, and the opportunity costs. With regards to the diagnostic gap, we need to develop a multi-step diagnostic algorithmic approach so that we can have, when we are assessing for the initial workup of a breathless patient, and this will help us identify, assess, and manage the acutely breathless patients and stabilize them, and also stabilize the underlying reversible pathologies. And lastly, screening for CRDs is important, and early management should be prioritized to avoid complications. Thank you.
Thank you, Wanjiku, for the presentation. So I think we'll move on to the next one. If there are any discussions, I'll come later on. I stand to be guided, Kevin. But just for housekeeping, Sam.
Yes, please.
I think just to help time along the slides as the presenter goes along, but the presenters, please feel free to say next.
Yeah,
slide.
yeah.
Okay.
Thank you.
So yes, next we go to Irene. Welcome, Irene from Uganda. Karibu. Jackie, please mute yourself.
Oh, sorry.
Thank you. Irene?
Hello, can you hear me?
Now we can.
Yes.
Oh, sorry about that. So I'll be, hello everyone. I'll be presenting my work, a very brief summary. It rotated around health worker experiences, patient experiences with communication about chronic respiratory diseases in Kampala. Next slide, please. So what were the insights and new knowledge? First and foremost, just to say that communication is very important, and it takes on many forms. We looked at person-to-person, spoken, verbal communication, and observed written and the use of documents from health worker to health worker, and that is how we described communication. Our findings pointed to the fact that health worker and patient experiences pointed to fragmented communication within a fragmented health system. There were several challenges, especially with linkage between the formal and informal sector, or from private to public health systems for patients seeking care for CRD. They sought care mainly to understand their altered lives that had been altered by CRD, and to fill in the gaps that existed due to challenges in communication. Patients always filled in the gaps through medical pluralism. Here they visited different providers, and it didn't matter whether they were formal or informal. Many of them used experiential knowledge if they had been, in the health system for protracted periods of time, and others still formed what is described in the literature as therapeutic groups, where they sought for understanding of their symptoms and disease. Another finding, maybe not too novel, but that was key, is that communication is mainly provider-centered, and does not meet the health worker and patient expectations. There were key knowledge and understanding gaps. First, for the patients or people seeking care, it was lack of understanding of their symptoms and illness, which led to widespread frustration with the system. But for health workers, it also affected the decisions they made for managing people seeking care. In this setting, from observation and from interactions with the health workers, there was no model for chronic care and no framework for health communication that was being used at the practice level. Another finding was that TB was an important link to CRD, and a lot of the communication around CRDs and lung disease focused on tuberculosis. However, it also presented a missed opportunity because after evaluation for TB, nothing much was done to evaluate further, just in case TB was not diagnosed, or especially if it was a post-TB condition. Next slide, please. So what do we think are some of the policy recommendations? Next slide. First and foremost, I think at the policy level, in Uganda, the current NCD policy under which the CRD policy lies is not operationalized. It is still in draft form and has been for quite a while now. And therefore, there is no standalone CRD policy. And however, I think one of the other key findings is that we probably need to understand how communication models can be tailored in this setting. And without a standalone CRD policy, it becomes hard to include the different aspects of CRD management in a policy. So I would advocate for a standalone CRD policy. I'm not sure what the experts would think about it being embedded in the larger NCD policy, but to build the different aspects of CRD management, a standalone policy might be essential. And for communication, we need a communication strategy to improve awareness, but also a communication framework, especially at the practice setting and for the wider community, to improve knowledge, understanding of CRD in this setting. I'm sorry for the old slides I used. I couldn't get the correct acknowledgement, but I acknowledge the funders and especially the patients and the other participants in this study. Thank you very much.
Thank you.
Thank you, Irene. Next, we'll have, is it Stephen?
Yes, Steve.
Yeah, Stephen Mulupi.
Yes, good morning, everyone. Good afternoon, Kenyans. My name is Steve Mulupi in the International Department of Health. And today I'm going to present to you about the findings. And my PhD overall aimed to investigate how the Kenyan public health system responds to people who present to public facilities with symptoms of chronic lung diseases. And today I highlight major failings in diagnosis and management of asthma at both the community and health facility levels in Kenya. Next slide, please. So our study overall, in summary, we looked at, collected some cost data, collected aspects of service delivery, and also linkages between community health system and the formal healthcare system. And so the first finding is that the current strategies for financing, sorry, I think the slides. Yeah, the current strategies of financing are not affordable to people with chronic lung disease in Kenya. And it's linked to the fact that there is very low health insurance coverage, and most people are having to use out-of-pocket to pay for their healthcare services. The second key finding is that the concerns and priorities of affected people, those with chronic lung disease symptoms, are not addressed by services provided. And this is associated mainly with the high levels of stigma that undermines appropriate diagnosis and management of chronic lung disease, including inhaler use. And our study findings suggest that there's need to for urgent interventions at both the community and facility levels. In terms of linkages between the community and formal healthcare system, the study established that these linkages are weak, and there are critical bottlenecks in terms of coordination of services that impede accurate diagnosis, essential and effective and affordable treatment, support, continuity of care for people with chronic lung diseases. Next slide, please. So what do we conclude? One is that the Kenyan government should enhance coverage and use of social protection mechanisms for chronic lung diseases. There's the National Social Health Insurance Scheme in place, but probably there's need to strengthen it and enhance coverage of people, and also considerations of other models of financing, and that the government and other stakeholders in lung health should invest in public education, primarily aimed at destigmatizing conditions like asthma, and that would hopefully enhance use of inhalers, including in public spaces. There's need to train healthcare workers and to enhance awareness and causes of on causes and management of chronic lung conditions. Then lastly, community health volunteers should be adequately supported, and they should be valued so that they can perform their roles of interface roles between the community health system and the formal healthcare system. And this could be done through provision of stipends, training them, providing supportive resources that they require for their day-to-day services. Lastly, the service delivery aspect should be strengthened, particularly in diagnosis and human resources. So, for example, in terms of payment of healthcare workers in time and promoting them, and lastly, in the supply of drugs. Next slide, please. So finally, I conclude with one excerpt from a community health volunteer, and this kind of demonstrates how the inadequacies in terms of support. One of them said that we are given empty bags, but no training. So in a way, showing their frustrations. I wish to, so this image here shows, so in the grand scheme of things, I'm the little bird that is perched on both the NHIR resources and goodwill, and also the support I've received from my supervisors and generally the IMPALA community. I'm grateful. Really say thank you so much. Bye.
Thank you. Thank you, Stephen. And we believe the buffalo is IMPALA and all the people that have supported you. So next we go to Martin.
Hello, everyone. Thank you. My presentation is titled Changing Lung Function, its Associated Health and Economic Burden Leading to Non-Communicable Lung Disease. This study has resulted from a cohort study of adults that we conducted in the past couple of years in Malawi, where we were able to collect data from 1,232 participants. Next slide, please. The main new findings from our cohort study were first, the general rate of forced expiratory volume at 1 second decline in our study cohort is comparable to a group of people of smoking 15 cigarettes a day in Europe and US in high-income settings. Second, the prevalence of COPD as assessed through spirometry patterns nearly doubled from 9.5% to 17.5% in the 5 years of our cohort study. Virtually all of it being undiagnosed, with only about 10% having some access to health services. And finally, lung function decline has an effect on the health-related quality of life of the participants. And this reduction in health-related quality of life was greater than minimally important differences and was associated with respiratory symptoms, especially breathlessness and wheeze, and abnormal lung function. Next slide, please. So, following on from our findings, our main policy recommendations are therefore: first, there is a need to plan for a substantial increase in recognized COPD in economically viable, relatively young people in terms of the impacts on labor productivity and health services use. This will lead to our second main policy recommendation, which the need to advocate for increased funding and inclusion into institutionalized budgets for low-cost lung function testing, such as spirometries, and the use of inhalers to improve the rate of diagnosis and treatment and management of chronic respiratory diseases, since most of it was virtually undiagnosed. There'll be need to ensure that it is managed once it's diagnosed. And finally, given the effects of abnormal lung function and the respiratory symptoms on the quality of life of those afflicted, the strategies to encourage adoption of effective approved preventive treatment and rehabilitation of guidelines should be pursued. This will help ensure that the burden of chronic respiratory diseases such as COPD and asthma are well addressed and well controlled and managed. Next slide, please. I'd like to thank my supervisors, Graham, Louis, Angela, and Jamie, and all the study participants, the collaborating partners such as Malawi Liverpool Wellcome Trust and the IMPALA members who assisted me through this, and the funders of this study. Thank you very much for listening to me. Okay.
Thank you very much, Martin. And to the whole team, before I hand over to Martin for chairmanship, I would like to say well done to my fellow PhD colleagues. We've seen across the board from, POCAS, communications, chronic lung diseases, and finally the health economist has now told us also, we need more funding for chronic lung diseases. So I'm going to hand over the chairmanship to Martin as I go ahead to do my presentation. Samuel, next. So my study was about introduction of operational modeling in policy uptake in Kenya, a case study of chest X-ray in tuberculosis screening. It was under the overall IMPALA strategic aim of improving health among adults in Africa through multidisciplinary applied health research on lung health and TB. Next. So the new knowledge that we bring in is that chest X-ray for TB screening identified a high prevalence of conditions other than TB, which were mostly associated with non-communicable diseases among participants who underwent mass screening as part of a population-based TB prevalence survey. And this was a first in a study in sub-Saharan Africa to describe and quantify the non-TB chest X-ray findings in this population. Secondly, is that computer-aided detection software for TB met the here I had said minimum, but we've completed the analysis. We actually met the optimum WHO target product profile for TB community screening when we used it in the TB prevalence survey chest X-rays. Therefore, it reached a sensitivity of 95% with a specificity of 85%. Now, again, this is a first looking at screening, accuracy of computer-aided diagnostic screening among the whole population, not just for triaging, but for all, even for asymptomatic population. So it needed a bit of latent class modeling, which we just completed. And finally, worked on developing a framework to introduce operational modeling for TB policy making in lower middle income countries. Next. So the new evidence-based policy recommendations that this study leads to is that first, as countries embark on chest X-ray TB screening activities, there's need for them to be aware that other treatable and preventable lung and heart problems are likely to be more or as prevalent as active TB. And therefore, we are recommending at policy level that national TB programs use this TB screening activities as an opportunity to integrate disease screening efforts. Secondly, is that computer-aided software offers an accurate and efficient approach to mass screening in low-risk settings, and this should actually be implemented now that it's also WHO, with a new recommendation from WHO that CAD can actually be used in place and in support of the human radiologists. And then finally, operational modeling was demonstrated to be a useful tool in the policy formulation stage to help project policy options. And therefore, we recommend that policymakers should consider this in the policy process, so incorporating modeling in the policy process. Next. And just to acknowledge funding from IMPALA through, NIHR through IMPALA, and also to my supervisors, but also in general to the IMPALA team that we've worked across countries and boundaries for this project. Thank you very much. Over to you, Martin.
Right. Thank you very much, Brenda. So I'll be moderating the second set of our presentations that will be done by the postdocs that you have. So Rebecca, Zalalem, Uzo, Elizabeth, and Yang. We'll start with first Rebecca Nantanda, who will give us a presentation from a cohort study in Uganda.
Thank you, Martin. Good morning, good afternoon, everyone. So in line with the IMPALA overall strategic plan of improving the health and children and adults in Africa, with a focus on lung health and using a multidisciplinary approach, we set out to investigate the determinants of lung function in a birth cohort that involved 564 pregnant women in rural Uganda. And we basically focused on modifiable factors, that is the mother's diet, exposure to air pollution, and socioeconomic status, which my colleague Zelalem will talk about. Next slide, please. So what new knowledge do we get from this birth cohort? I think the two major messages. One, there is the poverty of diet. And what we found that the diets of the pregnant women in this rural Uganda are not really adequate to support normal fetal growth of the lungs. And this was evidenced by seeing that less than 30% of the women actually frequently consumed foods that contain the nutrients that we actually need for lung growth and development. We went ahead to have some objective measures of nutrition where we measured serum vitamin D levels. And that pie chart just shows that up to 67% of the pregnant women actually have low levels. And therefore, this important nutrient is not consumed in optimal quantities to support the growth and development of the lungs of the babies in utero. And what this means that these children, once they're born, they're actually going to grow in these same households, same communities. And so we are likely to see a continuation of these dietary deficiencies, meaning that these babies are actually at high risk of having a really poor lung growth and therefore the high risk of lung disease throughout the life course. Next slide, please. So at the moment, we have done only the preliminary analysis. We haven't yet done the analysis to help us find out if these determinants are very significant within this community. And so I don't have upfront policy recommendations, but we had a lot of experience actually setting up this path cohort in this rural place. And I just want to share some experience from project implementation. I think one key lesson we learned was that continuous community engagement and involvement. One of the issues that we actually found that communities were not very receptive at that beginning, especially on issues around air pollution measurements. The devices, they had fears, they had anxieties, they had fears about the impact on their babies, on the mothers, their privacy, as well as the lung function measurements. But through continuous engagement, we're able to have a breakthrough, and we successfully completed the study. Next slide. So I just want to acknowledge the funders, the LSTM team, especially the IMPALA team, the team at Macquarie University Lung Institute, where the study was anchored, as well as the participants. Thank you.
Thank you, Rebecca. Our next presenter is Zalalem, who is doing a health economics and clinical sciences joint project on nutritional exposures and energy poverty. Over to you, Zalalem. Are you able to hear me, Zalalem?
Hi, Martin. It's Martina here. If it looks like Zalalem is not online, I'm going to try to connect him to the call. In the meantime, if Samuel wants to jump to the following presenter, and in the meantime, I'll try to get Zalalem on the call.
The next presenter is Uzo, who will give us a presentation on a package of care for patients with chronic respiratory diseases in Sudan. Over to you, Uzo.
Thank you, Martin. So good morning from Liverpool and good afternoon to those of you outside of here. And I will be talking on behalf of the Health System Social Sciences discipline to talk briefly on our findings from Sudan, where we set up a package of care for patients with chronic respiratory disease. Next slide, please. So what is the new knowledge, or what are the new insights from our study? The first thing is that we set out in Sudan to institute a component of health system that never was there at first. So we set up community health volunteers, train them in recognition, referral, and follow-up of community members with presumed chronic respiratory disease. And we know that before the project started, the epidemiological laboratory, who are our main partners in Sudan, had a well-developed asthma case management program or chronic respiratory disease program that was domiciled in certain health facilities in Jazeera State, but didn't have a component at the community that would link this system, this care, to the community. So this was what we tried to do. And in 6 months of implementing this, we could see in the graph that if we look at the blue side of it, it shows us the contribution of the community intervention. So these community volunteers we set up to all the activities leading to diagnosis of chronic respiratory disease. So we can see that in 6 months of intervention, out of about 800 people presumed to have CRD, 300 of those were found by our community volunteers and sent to the health facility where all those diagnoses were made. This one, at baseline, we didn't commonly find chronic obstructive pulmonary disease across both countries where we worked, but this time just one case, but it came from the community. But we believe that the component called other CRDs, probably we have COPD when proper diagnostics are applied. So the second thing we found was that CRD-related stigma is pervasive and is a malleable concept. It's related to tuberculosis and therefore associated with poverty and heredity. And of course, in the times of COVID, we can see that it's also linked to it. And it impacts care seeking, effective treatment, and patient quality of life. The third important point was that in addition to socio-cultural understanding of disease, the patient trust and the experience regarding how chronic respiratory diseases could be diagnosed and treated was linked to lack of resources at different levels. So at individual level, there were the issues of cost to travel and medicines. At local level, there was the issue of availability of diagnostic equipment and human resources that are trained to manage CRD and availability of medicines. And at national level, there was a lack of prioritization of care of chronic respiratory diseases. And these underpinned is underpinned by the recent economic crisis which the country has experienced and exacerbated by the COVID-19. Next slide, please. So what are the policy recommendations from these findings? The first is that the development of effective strategies to counter the pervasive CRD-related stigma, it requires sustained engagement. And this has to happen throughout the health-seeking pathway, including at the level of communities, primary healthcare, at secondary and tertiary levels. Secondly, equitable and effective and sustainable diagnosis and treatment for chronic respiratory disease would require wider health system support and enabling infrastructure as well as integration. And this also has to happen across community, primary and secondary care levels. There's also need to standardize this practice across these levels so that the preparedness to accommodate all the components of standard case management could be effectively seen across all these levels of care. Then finally, CRDs need recognition and visibility, and there's needs to include them in the development of patient-centered, non-communicable disease programming for chronic care. And this will be important to tackle multiple morbidities, mental and psychosocial ill health, which tend to be related to chronic respiratory disease in these settings where we have worked. So the next slide. And finally, to just acknowledge the funders, as my colleagues have already done, and also to thank the participants in our study in Sudan and the colleagues in country and all the partners we've worked with within the country who have made all these things happen. Thank you very much.
Thank you, Uzo. I think we'll move back to Zalalem's presentation. On the nutrition exposures and energy poverty and lung function of infants in Uganda. I hope you're able to hear me now, Zalalem.
I can hear you, Martin.
All right, thank you. Then take it away.
Thank you. Okay, so this work is a joint work with the clinical team. My presentation complements what Rebecca already presented. So specifically, I will be talking about the key results around the nutritional exposures, energy poverty, and the lung function of infants in Uganda, the birth cohort study. But in addition to the birth cohort study, we've conducted analysis of the national level data using the Uganda DHS dataset from 2016. So my talk would be around combination of the cohort study results and the DHS dataset Uganda result that we believe would complement one another and helps us to generalize the result from cohort study to the national level. The next slide, please. Okay, so our results contribute to the IMPALA strategic research objectives that strives to address the effectiveness and affordable environment related to household determinants of lung health. In particular, our study focused on access to clean energy and the nutritional exposure. In terms of nutrition, we looked into two focal points, like at household level and individual level. At household level, we assessed household level food insecurity using the food insecurity food consumption score. And for pregnant women, we assessed the dietary diversity using the validated tool that collects data from 24-hour food consumption of women. So in terms of nutrition, our results are around household level food insecurity and individual level dietary diversity. So the result indicates that the result from the DHS Uganda indicates that the multidimensional energy poverty index is strongly associated with acute respiratory infection among children who are under 5 years of age. We believe this would complement with the result from that we would expect from the cohort study, but the problem here is based on the response from mothers on children's experience of some symptoms of acute respiratory infection, and it's not measured. So our result from the cohort study indicate that the high proportion of pregnant women had very low dietary diversity during the antenatal phase. It's somehow comparable with other states in Africa, but still lower, and a very limited percentage really achieved the required dietary diversity. That means it's likely that those pregnant women were micronutrient inadequate. At household level, our results indicate that the household food insecurity is pervasive, and almost everyone is energy poor. That means they had no access to clean energy sources with health implication. So the next slide, please. Okay, so yes, in terms of policy recommendation, yeah, it is possible to draw some macro level lung health determinants from the cohort study as well as from the DHS dataset, but because we are still not there and we are not able to really draw specific policy recommendation regarding how the energy poverty, household level food insecurity, and the dietary diversity of women could specifically are associated with lung function of infants, because we still are working with the data set due to the complexities of the study and the design and all challenge that we could mention it. So yes, we can't draw specific policy recommendation, but still the new evidences on harmful exposure, that's poor access to nutrition and energy poverty, which means lack of access to clean energy, could really improve our understanding of the macro level determinants of exposures. And this could potentially be an entry point and a priority for intervention to address the burden of respiratory diseases, of course, through multi-sectoral strategies. So our policy recommendations are around the exposures, and we would like to highlight that those exposures could be an entry point for policymakers to, of course, address the planetary health as well as the burden of respiratory diseases from children and as well as at population level. So we would suggest the investment toward this addressing energy poverty could be one priority area to promote lung health, and that could, of course, help us towards achieving access to clean energy source, which is one of the key sustainable development goals. So those are the policy recommendations, but still we want to emphasize that we are not able to draw specific policy recommendations at this stage, but our policy recommendations are based on the results from the exposures. So yes, the next slide, please. Yes, we would like to thank the funder, the NHR, and all our collaborators and our senior investigators and local partners in Uganda and the population in Uganda and all those who participated in the study and who patiently gave us their time to give us the data. Thank you very much for attending.
Thank you, Zalalem. Our next presentation from the health policy discipline will be from Elizabeth Shayo, who will give us a presentation on an integrated approach for improving health services for chronic respiratory diseases in Tanzania. Over to you, Elizabeth.
Thank you. Good morning, Europe. Good afternoon, Africa. I'm Elizabeth Shayo, working with National Institute for Medical Research in Tanzania, and I'm going to present the IMPALA work that was implemented in Tanzania. As you can see in the right-hand side, there is a map of Tanzania showing the study region, which is Dodoma and Chamwino district, where this study was implemented. And this work was done jointly, as you can see the list of investigators. Next. Our work had different phases, including baseline assessment, implementation, and evaluation. And in the baseline assessment, the critical gaps were revealed in the health system functioning, including low capacity to diagnose chronic respiratory diseases, which was attributed by lack of human resources and diagnostic tools. It was also revealed low prioritization for CRD, and hence low resource allocation, and the main reason was due to lack of data. A lack of data was attributed due to the fact that the health information system did not have specific variables to capture CRD. As you can see from the graph, at the baseline we have no case for post-TB diseases, and we have a single case for COPD and some asthma cases. And again, there was no clear pathway for patients who turned out to be TB negative. So in the stakeholders meeting, it was proposed that to train health workers and to supply diagnostic tools at primary and secondary levels to be able to improve identification and diagnosis of chronic respiratory diseases. And this work was now implemented in 7 health facilities, where 5 of them were provided with peak flow meters and 2 were provided with spirometry. And a clear pathway was developed to ensure that all people who turned up to be TB negative are channeled properly to CLD care. And during implementation, the pathway that was developed was found to be effective, as those who tended to be TB negative were able to access the services and of high quality. Hence, it increased the feasibility within the routine data. It was also noted the improved quality of life, as it was reported by patients themselves and healthcare workers. Although, as we can see from this graph, we see now the increased number of CRD cases for post-TB lung diseases, for COPD, and substantial increased numbers for asthma cases. And this was only the follow-up of 6 months intervention, where we can now see the substantial increased number of chronic respiratory diseases. Although we have seen the notable improvement in terms of CRD management, there are still critical gaps in the health system building blocks. And these challenges need to be addressed, as they undermine the equity of services access and pose threats to sustainability and scalability. What is the message do we have now for policymakers? Next, please. As we continued implementing this, integration of chronic respiratory diagnosis and care into the TB program and strengthening the linkages with community health workers is feasible and acceptable in increasing the identification of chronic respiratory diseases. What is more, investment in all health system building blocks and attention to the health system software, including communication, support, and trusting relationship, will be important to sustain an integrated approach and ensure it contributes towards health system strengthening. And more important, appropriate management of chronic respiratory diseases improves quality of life of patients, but wider health system integration and psychosocial support will be needed to improve the lives of patients with multimorbidities, for example, on mental health. Next. We would like to thank all research participants, participating facilities, partners that we will work together in LSM and in Sudan for collaborating nicely in this work. And more important, we thank the National Institute for Health Research for funding this work. And also we thank the EpiLab Sudan for sharing their training materials and asthma experiences, as they had a good asthma management clinics. Thank you.
Thank you, Elizabeth, for a wonderful presentation. Our final presenter is Yang, who will present work from the Moody project.
Thank you, Martin. Hi, everyone. This is Yan speaking. I'm a postdoctoral researcher based in the Liverpool School of Tropical Medicine. And today I'm going to present to you the Moody project and relating learnings and actions for fostering cross-disciplinary research in global health. And the ability to conduct cross-disciplinary research in international collaborations is critical for improving global health. And based on our literature review, existing evidence on fostering cross-disciplinary research is fragmented across disciplines, and there are many from high-income countries, while in global health research, it's mainly conducted in global North and South collaborations. So this research, so the existing evidence are less applicable to global health research. And IMPALA involves 5 groups of research disciplines. And we took IMPALA as our case study to learn how to foster cross-disciplinary research in practice. Next slide, please. So the new knowledges, the first one is the cross-disciplinary aspect of research programs need to be actively managed. And one way to actively manage it is we need a series of indicators to plan and track the cross-disciplinary research. And based on our interview findings, it's good to have discussions among our research members to have a pre-agreed indicators to use. And the last findings I would like to emphasize is fostering cross-disciplinary research really takes time. And I'm sure this is not very new findings to you, but just want to emphasize it always takes more time than we may expect it. And because cross-disciplinary research needs lots of communications, and it always needs an explicit, continuous discussions. Next slide, please. So based on the findings, we recommend manage cross-disciplinary relationships separately from activities that focus on research outputs. And the thing is, fostering cross-disciplinary research actually requires its own planning and activities. If they're not separated from the research outputs, it always will be off the priority list. And then the second recommendation is review the progress in research planning, implementation, and management against the pre-agreed indicators. And based on this review, then troubleshooting accordingly. And the last recommendations are mainly to research funders. And because cross-disciplinary research really requires loads of time, and it's very important to allocate more time and more fundings for the active management of cross-disciplinary working in research planning. Next slide, please. So I would like to acknowledge our funder, the National Institute for Health Research, to fund this research. And also, I'm really grateful to each and every of you from the IMPALA community for your active engagement in the Moody research, to share your insights, to share your experiences with me. And thank you very much.
Thank you, Jan, for that presentation. We have about 10-ish to 15 minutes for a couple of questions specifically to the PhDs and the postdocs. So if anyone has a question, this is your time to rise up and ask the question. Just before you ask the question, specify to whom you're asking, and then the person will be able to respond accordingly. Go ahead, Angela.
So thank you so much all of our wonderful PhD and postdoc students for presentation of this work that spans really almost the entire pipeline of care and identification, care, identification, access, and provision of services, and also to Jan for this really careful work that you've done around cross-disciplinary research. So if I can start with Jan, what kind of indicators, since we've got some donor representation in the meeting, what kind of indicators would you be recommending? Would be a question to Jan. And then separately in the chat, Asma has responded to the excellent presentations by Uzo and Eliza around the health systems for non-communicable diseases, lung diseases. So I wonder if Asma might say some of the changes, summarize for participants some of the changes that you feel that IMPALA has already contributed to in Sudan. So two very different questions emerging from this session this morning.
All right. Would Jan first respond and then Asma to expound further? So Jan.
Okay. Hi, Angela. Thank you very much for your question. In terms of the indicators to track and plan cross-disciplinary research, I would say it's mainly about qualitative indicators. And for us, we realized at the research planning phase and implementation phase, there are certain things to do. And a third component is management and leadership component. So we have developed recommendations based on those three components, and each component have key recommendations, and these recommendations is also relevant, more like a qualitative indicators. For example, at the planning stage, allocate adequate time to develop a shared vision and goals. And then in terms the indicator, for example, co-design the program goal, aligning individuals' expectations and project aims with the program level goals, and then involve all partners, and then also justify and communicating the cross-disciplinary approach among all program members. So from these examples at the planning phase, you may see all those are not traditional quantitative indicators. It's more like those different aspects to take into consideration throughout the planning to implementation phases and across all phases in terms of program and project management. And I hope I answered your question.
Thanks, Jan.
Thank you.
Asma?
Yes, the health component program on asthma and tobacco cessation has been going for quite a while in Sudan. But the fact that another country, another law-setting country like Sudan, Tanzania, is replicating our experience, attracted the attention of the policymakers and put back the health system, program on the spotlights. And so what we were trying to achieve over the past 4 or 5 years, we did achieve it, because we needed to attract the attention of the Ministry of Health that standard case management is important, recording and reporting of patients, and finding the treatment results of asthma patients is important, but we failed. So we didn't gain only by replicating the community component from Tanzania in Sudan, but it gave a lot of advocacy around the existing health services program, which existed for a quite time. And now the Ministry of Health has agreed to move with the project from 2 states to another 5 states. With, the first step they took is the appointment of the state coordinators in the 5 states. And the second issue they are heading to do, and we did receive support for training, is the standardization of health services to be able to accommodate lung health, because this is an important issue. Health services are not ready and standardized, with the equipments, with the drugs, etc., to accommodate asthma and other lung diseases. Thank you.
Thank you, Asma.
Thank you, Asma. It's wonderful to hear that catalyzing effect.
Thank you. I have a questions in the chat, so I'll try and address that. So from Martina, she asked me specifically what I meant by minimally important differences, which are independently associated with respiratory symptoms. So when you are looking at the health-rated quality of life, you can be able to see the differences between, since it was a cohort study, there was a health-rated quality of life measure at baseline and then a health-rated quality of life measure 5 years later. You can be able to assess that difference and see if that difference has an impact. So the minimally important difference is defined simply as the smallest difference in score. The smallest difference in this health-related quality of life score that is perceived to be beneficial and therefore should be mandated. It's a difference that is important enough that should be clinically addressed to improve the quality of life. That is what that means. I hope that answers your questions, your comment, Martina. Right. Thank you. Any other questions? Comments, questions?
Yeah, Martin, sorry, can I just a quick comment? So I just want to thank my colleague Elizabeth for a very clear presentation where she mentioned, what we got from Sudan side. So I just wanted to quickly emphasize the importance of the inter-country learning that we experienced throughout this IMPALA work. So one of the reasons why, or a major reason why the health systems project was based in these two countries was that we saw that the health systems were complementary. So there's something that Sudan needed to learn from Tanzania, and there was something Tanzania needed to learn from Sudan. So Sudan has got a well-functioning CRD program that was focusing on asthma, and Tanzania had got an excellent community health system that works in the TB program. So Sudan learned a lot from how Tanzania has organized the community health system, and that helped us to design the intervention on Sudan's side that we have now seen is yielding not just CRD, but also improving detection of tuberculosis. And on the other hand, the experience of Sudan in organizing CRD services was also used to design intervention in Tanzania. So this is a real important thing that IMPALA has brought to the fore, the very strong impacts that inter-country learning brings into global health inquiries, such as what we've done. So this is something that I'm looking forward to us taking forward in some way and in whichever platforms we find ourselves. So I just wanted to emphasize that and also thank Tanzania for the opportunities that that side provided for the research in Sudan. Thank you.
Thank you, Uzo. If there is one question from Miriam to Yang specifically, and she asks, how well did we do in multidisciplinary research in IMPALA against our target to work together? Before Jan takes responding to that, Asma, could you please mute your speaker? Right, Jan, could you please respond to the question on how well did we do in multidisciplinary research in IMPALA against our target to work together?
Yeah, sure. Thanks, Martin. Thanks, Miriam, for the question. In terms of the multidisciplinary working in IMPALA, I think we have a very good start to put different disciplinary group in equal position, and which means each disciplinary group have a representative in the management team, have equal fundings with one PhD position and one postdoc position. And I think this is a very good start. And in terms of cross-disciplinary working, a psychological safety to speak out, to share views and expertise with each other, it's very important. And in this regard, we did a great job, and we provide lots of support to early career researchers and encourage early career researchers to learn and to share, to grow. And also provided a great opportunity for global South partners and global North partners to build research network for future collaborations. And so all those are repeated themes from my research fundings. And in terms of working together, like I said, cross-disciplinary research really takes more effort than we expected, and it takes more time. And it needs lots of communication. And because it takes time to get things communicate clearly, properly. So I think what we did well is we are very adaptive. We identify problems and try to adjust. So it's a continuous reflective and negotiative practice and learning process. And for example, we identified we really need a platform to promote the knowledge exchange. And then based on these feedbacks, we have established our monthly knowledge sharing meetings, knowledge exchange meetings. So I think in general, it's a great it's a great effort that we are open to learn from each other, to respect each other. But of course, we also along the way we identified space that needs to be improved and generate lessons for future research study. So yeah. To summarize, I think in general, we are making great effort. We identify the things to do. Just want to emphasize, it may be if we have a way earlier communication, engaging every of us regarding what does multidisciplinary research means for us in practice. That would be great. Miriam, I don't know whether I answered your question.
Thank you, Jan. I think you it was close enough. Thank you very much for everyone for the morning sessions that you've had and the presentations that you've had. Next, we'll have a 20-minute break, followed by sessions moderated with Irene and Mulupi on cross-partner projects. And thank you, everyone. We'll be back at 12:35.
Thanks so much, Martin. Thank you.
Right.
You're on mute, Sam. Are you trying to say something?
Oh. Yes. We start.
Yes, sure. So welcome everybody back to into this session where we're going to listen, or rather have discussions based on the presentations that are submitted by our partners. So in summary, we have 7 presentations. First from Amsalu Bekele from Addis Ababa University, Ethiopia, Adegoke Falade from Ibadan University, Nigeria, Kobile Ndimande representing Pat Meko, Emmanuel Oboyodo from Ghana, Brian Alud from Stellenbosch University, Mr. Bertrand Bacho from Douala, Cameroon, and lastly, Lindsay Zuba, who presented on spirometry training and development in South Africa. So would wish to invite questions and reflections on 2 presentations each before we move to the next pair of presenters. And then lastly, we'll finalize with reflections on spirometry training by Lindsay Zuba. So I welcome your questions. So we start with the reflections on Amsalu Bekele and Adegoke Falade from Ibadan. Questions, please. Reflections.
Stephen, Kevin has his hand up.
Okay, great. Kevin, please go ahead.
Hi, I thought I should ask something to get things going, because it's obviously difficult to get things going like this in the same way that it's possible to do when we're all together somewhere. So I think Amsalu and Falade, can I ask each of you in turn to say what was the main thing that you found, and what impact will it have locally? And that might just help get some discussion going.
Thank you, Kevin.
So who is going to start?
You are.
Okay. Okay, I can start. I'm sure a lot of us, can you hear me? Can you hear me, please?
Yes. Yeah, we hear you.
Okay, thank you very much. I'm sure we are aware of Isaac studies, Isaac phase 1, 2, and 3. But I'm concerned with Isaac phases 1 and 3 here. Ibadan took part in Isaac phases 1 and 3, where we measured prevalence of symptoms of asthma and then the severity. When we compare the values of Isaac phase 1 with Isaac phase 3, we could see a significant increase from 10.7% to 13.0% in 13 to 14-year-old adolescents attending secondary schools. And we thought we had an epidemic of asthma going on. When Global Asthma Network phase 1 study came on board, we also took part. And we used the same methodology, exactly the same methodology as Isaac phase 1 and 3. And lo and behold, there was a general decrease in the prevalence of all the measured, in most of the prevalences of all the measured values. And we looked and searched what could have been responsible for this. We couldn't find any reason for that. Maybe I should just quickly say that the increase in the asthma prevalence in the adolescents in Ibadan from Isaac phase 1 to Isaac phase 3, which was about 6 years apart, we couldn't also explain this decrease. And it could not be explained by hygiene hypothesis. But in the GAN phase 1 study, what we detected in addition was that access to salbutamol and inhaled corticosteroids was very, very poor among these adolescent secondary students. So we thought that if we could improve that, maybe there will be a further reduction in the prevalence of asthma symptoms. So that is just a summary of what we have done.
Thank you for that summary. We move to Amsalu Mekele.
Stephen, is Amsalu with us? If not, there is a question for Professor Falade in the chat room.
Oh, let me see.
That's from asthma.
Yes, from asthma.
Okay.
Okay.
So, Professor Falade, if I may just relay
so
the question.
I'm just reading it. Or maybe you can read it for me.
Sure. Okay, sure. It says, since ISAC back in 1995 found an increasing prevalence of current wheeze from 10.7 in 1995 to 10.6 in 2018. I think you agree with me that there isn't appreciable decrease in asthma in the past 4 decades. Are you contemplating convincing policymakers in Nigeria, being the most populous country in Africa, that it's high time for programmatic management of asthma?
Sorry, maybe I want a clarification. Isaac phase 1 took place in 1995. Isaac phase 3 took place in 2001, 2002, which is 6 years after Isaac phase 1. And the GAN phase 1 took place in 2018. When we compare the values of what we got in GAN phase 1 with Isaac phase 1, that would be 23 years apart. And then GAN phase 1 with GAN phase 3 will be 16 years apart. I just want to correct that duration. So back to your question, exactly. And that's what we are saying, that we need to tell the policymakers that it's high time they do something about it. So we need pragmatic management in the cases of asthma. I agree with you, Prof. But maybe I should repeat again. Maybe I should repeat again. Sorry. There's one thing that surprised us. That despite the fact that there was no improvement, when we look at our record, there was no improvement in the way we manage asthma. We still recorded a decrease. And we sat and said we couldn't find the reason. But when we also compared with other studies, especially from New Zealand, they also had the same experience with ISIC phase 1 to ISIC phase 3. That was a reduction. And they couldn't actually find a plausible reason for the decrease. So something is happening with prevalence of asthma symptom, the current asthma symptom, that nobody really knows what is happening. And this cannot be explained by hygiene hypothesis. For instance, why should we have increase in current wheeze in Nigeria from ISIC phase 1 to ISIC phase 3 when the status of our hygiene has not improved? And in the same way, are we saying that with the decrease, the status of our hygiene has now become poorer? So it's a little bit not too straightforward. Thank you very much. Graham, I can see a question from Graham. Can I go ahead?
I think.
Should I wait?
Yeah.
Okay. Maybe I take that next.
Okay, great. So I'll request for the rest of the videos and questions, please keep them coming through the chat. But now we move on to the next two presentations. That is from Kobile Demande on Pat Miko, highlights of achievements, and Emmanuel Obo Yodo from Ghana. Your questions, reactions, please. Okay, maybe I would start this discussion or reflections. First of all, from the Pat Miko presentation, it strikes me that there's been a report of progress, but then there are still disparities. For example, the gender disparities, as well as in terms of publications, as well as between international versus local publications. That trend shows that males are kind of publishing more, almost double what the female collaborators are doing, apart from the first author where the female scientists are leading. Just wish to get your reflections about these findings. Kevin, I see you associated with this paper, with this presentation, Pat Miko stuff. If you could please respond.
Oh, I wasn't expecting to be asked to respond. I was busy writing a profound statement in the chat, which I've now now sent.
Okay, Kobile. Is Kobile here?
Well, Malupi, were
Jen, please.
Did you want to hear something about Pat Miko and the impacts we've had in PATS and so on?
Jen has a hand. Please proceed, Jen.
Okay.
I put a question in the chat about thinking about the future of Pat Miko and the impact of COVID-19 and the general move to online learning. Whether there'd been any thoughts about that, I wondered.
Thank you, Jen.
Should I respond to that?
Sure, please.
So, in fact, just last week, PatsMeCall was online for the first time ever. It was as a stopgap, really, because of course we had intended to have PatsMeCall for real last year in Cameroon. That was deferred to this year, and of course we have yet to do the in-person PatsMeCall, but absolutely must do so if at all possible. Making the most of the underspend that we're allowed to utilize over the coming 2 years. So I was involved a little bit in the virtual PatsMeCall. I think the bottom lines are definitely better than doing nothing at all, but really very much a kind of keeping the plate spinning intervention. So much more difficult to do the collaboration building, network making, co-creation of projects, bringing people together who would otherwise not get to meet, trying to do so remotely. Maybe there'll be scope to do a little bit more of the online stuff and thinking creatively about that. But I think it's clear that we've very much missed the opportunity to get together in person.
Thank you so much, Kevin. Yes, please. There's another question. Okay, then we move to the findings by Emmanuel from Ghana on building capacity in diagnosis and management of asthma. Your reactions to this, please. Okay, go ahead.
It might be helpful to stimulate some discussion if Emmanuel's on the line and could maybe say a few words like Falade did.
Sure, please, Emmanuel.
Yes, good day, everyone. I apologize ahead because I've got a very bad internet connection. But long and short, we've whipped up a lot of interest for asthma and lung health, research and diagnosis. Looking at the candidates who were about leading to their various facilities, the obvious thing is they're probably going back to quote unquote an empty facility without the support. And I think that's where my main concern is. So far, we've been moving our spirometers and whatnots around for a period of, say, 2 weeks at a time for people who might need it in their various sections. But lobbying for the hospital officials to kind of support lung health care and research in terms of diagnostic treatments is an issue, because currently people are still thinking more about maternal and child health in the terms of obstetrics and gynecology and immuninatable, child health diseases, and of course other things like malaria. TB occasionally comes up as a strong program because it's got separate funding. But when it comes to asthma and that component of lung health, I think we've got quite a lot of lobbying to do, even though we believe in that when malaria is of the same, with the increasing prevalence of asthma, that is what we are going to see. I think we need to do some real advocacy on that. I had a chat with our non-communicable disease section, and it looks like data for them to base their action on is not strong and it's not comprehensive. And I think it comes from the clinic. So we need to support that diagnostic aspect from there as well. The other part is the triclosan study, and the long and short, we found an association between asthma severity and triclosan concentrations, but we did not find any relationship, a significant relationship between asthma control and triclosan levels. And I think the basic reason is that it is possible that some of the subjects we're dealing with may have had a review of their asthma symptoms recently meaning the last 4 or 6 weeks, and probably changed their medication to improve treatment, and that is what happens. So logically, the more logical relationship to look at, and which luckily we found, is a relationship with asthma severity. And we think that triclosan is still freely available in products that are marketed, and we think we should look seriously at banning it, since the US and the EU have already done that. Thank you.
Thank you so much.
Hello, I wonder whether...
Sure, go ahead.
My internet has been on and off, rather frustrating.
Thank you for that presentation. Kevin has a hand up. Please go ahead.
Emmanuel or Vlade, could you maybe just explain a bit more about where the idea came from? What made you think that triclosan was relevant, and what do you think needs to be done next, perhaps from a policy or advocacy perspective?
Right. So the background of our study was, I think we came across the publication from the US FDA and from this NHANES study about triclosan. The history was that it had been introduced in the US for a period of about 10 years, and they found an association between sensitization, the development of sensitization, and the exposure to triclosan. And it was on that basis that it was banned in products in the US and the EU since 2017. But anytime these things happen, it takes a long time before it trickles down to developing countries. So that was where the idea came from. So we started looking at whether there are any triclosan products in our 2 countries. And we found them in toothpastes and in soaps, most commonly in the populations in Nigeria and Ghana we studied. So that is where the idea came from. And we were just supposing that against the fact that the observation that asthma prevalence is increasing into the 2 countries. So the question was, what was the reason, or what are the contributing factors to this increase in asthma prevalence? So if we may not be able to do much about diet and the environment, even though we're trying to work on that, one of the most important things we thought we could address was triclosan containing household products, which we think that with a strong advocacy, of course, there are many alternatives. So it's not about starving the population of their favorites. We could get alternatives for that. And some of us have started advising asthma patients that if they can, they should avoid that. Classically, there are medicated soaps and toothpastes, and there's a wide variety, a large variety of options for these products to allow them to avoid triclosan-containing ones. Again, was I audible, Kevin? Hello?
Yes, thank you.
Yeah.
So quickly moving on, thank you very much for that.
I hope I was audible.
Hello? Yes?
Oh dear.
Yes, you are. We could hear you, Emmanuel. Thanks.
All right, thank you. We have 2 more presenters, Brian Elwood from Stellenbosch University They did work on an audit of admissions and tertiary outpatient services, and some work on post-TB lung disease. We already have a question for you, Brian, in the chat, and it's for the, how much were the team able to link to community-based stroke palliative care for patients with post-TB lung disease, whom I presume visits to hospital will become more and more difficult. So, Brian?
Yeah, thank you very much. Yeah. So this is a real work in progress. What you're asking about post-TB lung disease, and I think we haven't, what we haven't done is we haven't taken the work back to the community yet, because we don't fully understand either the disease or what the best option to do it is. So what we're trying to do is in our context is by creating a rather a center of excellence for post-TB lung disease, is trying to learn from our patients as to what the best strategy is and what the best way forward is. Unfortunately, we were getting some very nice momentum in the beginning of 2020, and we have basically had to, because of COVID and lack of capacity, close all our clinics for about 12 of the last 18 months, which have only just reopened in the last week or so. And so that has massively knocked our momentum for the whole program. Ultimately, that's exactly what we're wanting to do. We're wanting to take it back into the community. In terms of community care, I'm a little bit concerned about the term palliative care in post-TB lung disease, and definitely there are patients who do need palliative care, but I'm not sure what I can't speak for other countries, but one of the concerns that I have with patients who have post-TB lung disease is they're written off. And they have very badly destroyed lungs, or sometimes not so badly destroyed lungs, and the medical community and colleagues and just write them off as there's nothing more you can do, palliation. And I'm not sure that that is necessarily true. Much like you wouldn't write off necessarily a patient with bronchiectasis or a patient with COPD. And so I think we have to do a lot of advocacy in actually helping people, because, you know, these people didn't choose to have this disease. A lot of them have got it entirely coincidentally for reasons we don't fully understand. And so we really need to walk the path with them. Yes, decentralized care is absolutely essential, and hopefully we'll be able to develop these programs in the next few years to decentralize care. But we're still a little way off of that, and you know, there is actually almost no evidence for pretty much anything, possibly with the exception of some small amounts of evidence for pulmonary rehabilitation for post-TB lung disease. So yeah, it's a very good question, very important question, and you know, we're wanting to have a backwards and forwards community conversation with community teams where they inform us of their needs, and also that we can and we can refer patients back to them as well once we know a bit better what we're doing. So it's very much a work in progress, but a very important question.
Thank you very much, Brian. There is another question in the chat room. However, in view of time, I would suggest that we listen to Bertrand Mbachu from Cameroon, who did some work about on TB among patients undergoing hemodialysis. There's no question for him yet, but he can give us a very brief summary and maybe recommendation as and if there's still time, we'll circle back. But Brian, you can check out the question in the chat room. I think there are two.
Thank you.
Thank you. So Bertrand?
Hello?
Yes, please. A very brief summary of the work you did, or a policy recommendation, a take-home message for us, perhaps. There's no question for you yet in the chat room.
Yes, without the presentation, I will just say it like that without the screen. Hello, Brenda? Hello.
Yes, Bertrand, yes, it's Martina here. Just a quick overview, our take-home message, as Erin was saying, taking from the presentation. All the attendees should have listened to it already. So if you can just give us a bit of a take-home message. Thank you, Bertrand.
Thank you very much, Martina. So our IMPALA team in Cameroon did some work on tuberculosis among hemodialysis patients, chronic hemodialysis patients, and found a high prevalence of tuberculosis of about 13% cases of tuberculosis, and chronic hemodialysis were noted as a risk factor of death among these patients. We also did some monitoring of PM2 particles and carbon monoxide among street vendors and motorbike drivers. You know, motorbike drivers are very common in our cities in Africa, and we measured arterial stiffness among them. We found an increased arterial stiffness among this and more respiratory symptoms among these street vendors. We also did a survey among university students in Cameroon, in Buea, smoking of water pipe, which is called shisha, which is very common and very increasing in use in our country. We found a high prevalence with 26% of university students smoking shisha. The risk factors being male gender, living in hostels, smoking cigarettes, having friends or siblings that also smoke shisha, and poor knowledge about shisha. And from these findings, we had some recommendation according to policy. We are recommending that we should screen tuberculosis, whether clinically or biologically, in patients running chronic hemodialysis, and especially those in hemodialysis care since at least 12 months. And we think we should also advise street vendors and motorbike drivers to be wearing masks, respiratory masks, to avoid exposure to carbon monoxide and PM2.5 particles. And as a third recommendation, sensitization campaign should be held in the community of university students in order to reduce the burden of smoking of shisha in this population. Thank you very much, dear Martina and
Thank you, Bertrand. Lindsay is our last presenter for this session, and please keep the questions coming. I just want each of the presenters to have an opportunity to summarize, and if we still have time, then the questions will be broadcast. Lindsay, please, a small summary, a key message for us. It's raining in Kampala, so I might not be very clear, and I apologize for that.
Can you hear me? Hello?
Yes, I can. I hope the rest can hear you. Go ahead, Lindsay.
Okay, so basically, thank you very much to everyone for the opportunity to develop training materials for spirometry and to actually give the spirometry training and mentorship and knowledge and quality assurance in the various projects. Our take-home points are that we were quite successful in many ways in transferring knowledge and creating a basis on which to work when it comes to spirometry. I think we've developed some people in our network as spirometry champions in the area, and I think those the progress that we've made is actually taking root in the areas that we've worked in, and is feeding out of knowledge across the continent, and I think that's due to IMPALA. But some of the challenges that we still have are availability of equipment. That's a big one, together with technical support in the areas themselves. So, you know, when things go wrong with equipment, it's difficult for people to fix it. And also some of the equipment that is available is very old and outdated. and isn't actually appropriate anymore for what we are trying to achieve, or rather I should say it's I don't want to say substandard, but it would be easier if we had equipment that was really working well to get high quality spirometry. So my take-home message is we've made good progress. We've developed some high quality spirometry tools, and access to spirometry is better off for the IMPALA program. Thank you very much, and thank you to everybody involved who worked with me on this.
All right, thank you very much, Lindsay, and for keeping it brief. I'm afraid we have run over time, but there are several questions in the chat room. I see a question for, I think, each of you who have presented last, and Amselu, we didn't hear from you, but there's a question for you in the chat room as well. So Martina, I think I hand over to the next presenter in view of time. And I'm sorry, I can hardly hear.
Don't
Yes,
worry.
Martina.
I think if the Q&A on the pre-recorded presentations is over, I think we hand over to Wanjiku for moderating the session on the auspices presentations. And just a huge thank to all the presenters so far. Amazing work. Thank you. Wanjiku, over to you.
Thank you, Martina. Thank you, Irene, for handing over. We are now at having the next set of presentation. Our first presenter is Jane Audrey. Jane, please go ahead.
Good afternoon, everybody. This very short presentation is about the health-related findings of my PhD research. Can we show the slides? And this fits within the social science discipline of IMPALA and relates to the impact of household air pollution on lung health. The overall aim of the PhD study was to gain a deeper understanding of the social context of the cooking and pneumonia study, CAPS. This was a cook stove intervention carried out in rural Malawi. So we wanted to really gain a view from the foot of the energy ladder, from the people using the cook stoves. Next slide, please. So we used the participatory methodology photo voice, in which research participants collect images which are then discussed. And we found that such methodologies can promote the concerns and strengths of communities and individuals exposed to household air pollution. Through using photo voice, we found that CAPS participants prioritised access to food above how that food was cooked. So Jenna can also refer to this as the food imperative. So essentially, the participants considered less the long-term impacts of household air pollution and worried about where the next meal was going to come from. We also found a disconnect between local context specific understandings of health and the biomedical messages of CAPS. And this led to unhelpful ideas, such as linking cook stoves and pneumonia going away, and also rumours that cook stoves were a mechanism for researchers taking blood. Next slide, please. So the implications of this is that we need to develop strategies to incorporate the views and prioritise of marginalised people who are exposed to household air pollution. Participatory methodologies such as photo voice can assist with this aim, but we need to be aware that this is a time-consuming and ethically challenging process. To avoid a tokenistic use of such methodologies, we really need to build long-term collaborative relationships with the impacted communities. Finally, when exploring such complex issues, such as air pollution, so-called wicked problems, researchers need to be aware that their research may have unintended consequences. And to avoid these or to mitigate against them depends on gaining a greater understanding of non-biomedical understandings of health, which can only be achieved by meaningfully incorporating community priorities into our research, and this takes considerable time and effort. Next slide, please. I would like to thank my PH supervisors, including IMPALA colleagues, Rachel and Kevin, and also the IMPALA and NIHR for funding my research. Finally, I am grateful to the Photo Voice participants for their enthusiastic and expert participation in the Photo Voice process, and you'll see some images here of the participants practicing their cameras, an image they collected, and also a focus group discussion in one of the target villages. Thank you.
Thank you so much, Jane, for an excellent presentation. We'll move on to the next presenter, Lucky. Lucky, are you ready? You can go ahead.
Yes, thank you very much. So this is Lucky Ngwira in Malawi. So I'm talking to you on my PhD work, which has been looking at childhood health-related quality of life in the context of economic evaluation. And why are we talking about childhood and economic evaluation? I think this, because it goes well in line with the SDG 3, which is about child health and well-being, and in the context of also providing the universal health coverage, we're looking not just at the clinical outcomes, which is looking at longevity of life, in other words, more lives lived, but also moving to health-related quality of life in terms of the quality of life. And then further to that, as an extension, is doing economic evaluation. In other words, looking at which interventions are cost-effective, which can be funded by governments in light of limited resources. Could you move to next slide, please? So my work set on looking at the definition of health, because as we can understand it, health is defined differently depending on the context. What might define dimensions of health in the West might not be the same as in countries with limited resources. And so I looked at preference, existing preference-based measures. So these preference-based measures are used in economic evaluation. And so I was concentrating on childhood, and that means children and adolescents. And among the identified instruments, there were 10 that were identified. And out of those, only 2, let's say, health utility instrument, 1 and the AQ5DY had been used in any old sub-Saharan African context. So I set up on my objective, which was to adapt an instrument for use and then psychometrically validate it in this Malawian context. So the EQ5DY, which has brought 5 dimensions and 3 response levels, and the counterpart, which is an EQ5DY 5L, which has brought 5 response levels, were adapted. So that means doing a linguistical translation, as well as doing a conceptual equivalence, and to see which dimensions, or to see the equivalence of those dimensions in this context. And in the adaptation, it dawned that actually some of the dimensions that are in the existing instrument are not related in this context. For example, looking after myself, which is one of the dimensions of EQ5DY, was not related here to the children. They were talking, or they thought about that dimension as meaning provision of things like soap and water. And this is in a Western context, it doesn't come to mind. But when you talk about in countries with limited resources, looking after myself and inability to look after myself, thinking about lack of these basic provisions. As well as I did a conceptual framework looking at the dimensions that the children found important using a focus group discussion. And there were quite similarities, but also there were some dimensions that emerged that are not included in health-related quality of life instruments. And so after the translation, I went to the next step, which was to psychometrically validate these. The ability was okay, but the validity actually provided mixed findings. Okay, if we can move to next slide, please. So what are the policy implications? What I'm saying from the findings is we are limited in terms of the existing instruments. So we can use the existing instruments, but then there's a caveat in the sense that there are some limitations. The EQ5DY is one, EQ5D, the adult version, is widely used in economic evaluation and in measuring health-related quality of life. And in our context, we do find that that can be widely used, but obviously, as I mentioned, with limitations. This can be used in research as well as in policy, and especially in Malawi, where we are setting up, it's just been set up a health economics policy unit. And in pursuit of universal health coverage, they have designed an essential health package. I believe that this instrument could be one step that can help in determining the cost effectiveness of interventions that can go into the essential health package. So has got a potential for use in that respect. And finally, just to mention, as I said, that there are some limitations in terms of the dimensions that are merged from the conceptual framework, would indicate that perhaps there's a need as well to explore the possibility of developing instruments that are context specific. Last slide, please. So just to thank my PhD supervisor, Louis, who I believe should be on this call, and there's so many people out there that have supported me, the MRC Norway for funding, and also for the Breathe trial, rather the IMPALA for funding me for the last 8 months of my PhD. I thank you very much for your time and for invitation to present. Thank you.
Very well done, Lucky. We are on to the final presentation of the day. Jane, please go ahead.
Thank you very much for the opportunity to present the work from my PhD looking at well-being, poverty and advanced cancer in Malawi and whether palliative care can help. Palliative care is a multidisciplinary intervention involving assessment of physical, psychological, social and spiritual needs of patients with life-limiting illnesses. And around 90% of the need for palliative care globally is unmet, and 80% of this need is in low and middle income countries. The World Bank and the Lancet Commission have suggested that palliative care can contribute to poverty reduction in low and middle income countries, but there is currently very little data to support these assertions. And this is what led to my particular study. I was looking at poverty from both a cost point of view and also from a broader well-being point of view. And this led me to do a mixed methods PhD, in which first I explored well-being concepts in households affected by a diagnosis of advanced cancer and looking at the contribution of palliative care to enhanced well-being. And then I undertook and then I developed and adapted the TB patient cost survey into a patient and carer cancer cost survey, which was used in a prospective cohort study of 150 households affected by advanced cancer, looking at catastrophic cost outcomes. Next slide, please. Thank you. In terms of new knowledge and insights from the photo voice qualitative study, the research highlighted that households with life-limiting illnesses, in this case it was advanced cancer, but I hope that we can extrapolate somewhat to some of the life-limiting conditions which are the result of lung disease. Those households value the support to improve function, having courage, and to avoid discrimination that they experience within their communities. Palliative care is relevant beyond cancer and supports well-being through providing medication to improve function and reduces discrimination by counselling and hands-on care. In terms of the cost element of the study which I undertook, palliative care supports a reduction in catastrophic household costs. Around 64% of households in Blantyre, Malawi experienced catastrophic costs in the 6 months following their diagnosis. This was reduced to 47% where households received palliative care, but it was not significant due to the sample size limitations. So larger studies are needed. In the adaptation of the TB patient cost survey, we were able to include a section on funeral costs, and this was found to be acceptable and feasible within the study design. Final slide. Next slide, please. From the policy recommendation point of view, where poverty reduction strategies are being considered in healthcare, these poverty reduction strategies should include the provision of palliative care within the continuum of care for households affected by life-limiting illnesses, whether that's cancer or chronic lung disease, COPD, and maybe post-TB lung disease in future in low and middle income countries. And the other policy recommendation is that patients and families affected by life-limiting illnesses can and should participate within inclusive policy formulation in low and middle income countries. We found this through some of the work we did in preparing for the Photo Voice study. Final slide, please. I'd like to very much thank my supervisors on my PhD, without whom I probably wouldn't have been able to benefit from the IMPALA network. And it has been a great benefit to me. A number of people presenting today have been very supportive and helpful colleagues, so I really appreciate that, as well as the funding for publication of some of the work which has been an output from my PhD. I'd also like to thank colleagues at LSTM and the Malawi Liverpool Wellcome Trust, who have very much supported this research. Thank you.
Thank you, Jane, for summing up with a very good presentation. Now going to open this session for questions. Please, I think we only have 5 minutes before the next session is due to start, and I think there was supposed to be a break, although I don't know whether we'll take the break or just dive into the next session. Any questions in the meantime? If I'm not able to see your hand lifted, you can just unmute yourself and ask the question. I think Martina, do you have a question?
Yes, thank you, Wanjiku. I would like to thank all the presenters so far, and I have a question in general for the presenters for the auspices, so Jane, Lucky, and Jane. And my question is more organizational rather than technical or scientific, and I'd like to know whether you found that this auspices formula supported you, if so, how? Because I suppose that IMPALA was one of the first programs to introduce this auspices kind of support. And I'd like just to know whether you found it helpful, and if so, how? And if you think that it would be worth replicating into other programs in the future. Thank you.
Shall I start?
Yes, please. Yes, please.
Hi, Martina. I suppose just an overall reflection is that including the auspices in this way in a large-scale program is really helpful, because it appreciates, if you like, the reality of PhD, studies which often go on beyond the plan length. And also, as Jane, when she finished her presentation, said, it really encourages a wider collaboration, which can be really useful. I think that's beyond the actual financial and other support and logistical support. I think those are the two main things. You know, it widens it helps people finish things in a considered way and to incorporate different experts, and so it links with the multidisciplinary aspect of IMPALA as well in that way.
Jen, do you want to comment?
I think I probably concur with Jane Ardrey, and certainly Jane herself helped me in the early days with setting up Photo Voice and maintained that interest. And I think the fact that IMPALA was willing to sort of include this slightly different sort of cancer-focused work, but with an interest in, you know, and concern for those with chronic and severe end-stage lung disease, and sort of seeing the potential of collaboration there. I think that was very much appreciated. I'm not sure I can say much about the auspices side of things, I'm afraid. I might need to understand more about that.
Thank you all. We have 2 minutes. Anyone else with any question or comment? 1 minute. Okay, so thank you all. I think I'm happy to hand over the program to Martina. Are you the one taking over now for the final 2 presentations?
Thank you, Wanjiku. I'll just hand over directly to, I think, Angela and Elia are chairing the next session on celebrating our success. So Angela and Elia, over to you. Thank you, Wanjiku.
Thank you so much. Elia, are you with me?
I'm here, Angela. How are you doing?
Okay, I'm very, very well. So if I may, what I was going to do was just quickly go through some reflections myself, and then hand over to Elia, who, as our policy lead, I think his reflections about next steps and what's on the horizon for policy impact might be the way to go. Is that okay?
Yes, just go ahead, Angela.
And if I may, I'm going to share. I'm going to share my screen. Now, please all throw up a prayer for technical compliance. Yes. Can you all see that?
Yes, Angela.
Yes, perfect. Okay, so it's just a couple of reflections really, and beginning and ending with thanks. First of all, I think I want to thank everybody for the really superb presentations that we had this morning. And it's always, there's always a concern when you're going to have a run of many presentations that it might be overwhelming or the message might get lost. But I think all the presenters did a wonderful job of being really clear and bringing out some really important take-home messages that, you know, kept me gripped throughout the entire session. So thank you all so much for that. And for those who have not had a chance to listen to the presentations that are in the link, which Martina has put in the chat, I really urge you to take a moment to listen to them and watch them, because, you know, it really does add a much broader context to what we've done today. So this is an opportunity to look back over 4 years, and for me, it's been helpful to just reflect on where we started and our NIHR colleagues on the call, thank you so much for funding this work, which was looking at, you know, two of the biggest problems really facing global health. You know, TB, which up until COVID was the biggest killer of the single biggest infectious cause of death. And if you look at those numbers, chronic lung diseases apart from TB were completely neglected, and even were a much bigger cause of morbidity and mortality than TB. And over the last 4 years, with the 7 million that you've given us an opportunity to really address this really important cause of suffering in the UK, in Africa, which has been our focus. I don't know who is. Thank you. Can somebody mute themselves? Whoever it is that's got a siren going in the background, please can you mute? I can't see the chat, but I'd be grateful if you would do.
Angela, I think you're muted as well now. I'm hoping no one's being carried off in an ambulance.
Right, okay, so somebody muted me, but I'm muted now. Can you hear me?
Yep.
Super. So going back to the very, very beginning, this was a presentation we gave at the very first, this figure was one that I put together for the very first IMPALA workshop, which summarized our approach, which was looking at the intersection of TB and other lung disease. And these were the areas that we had identified in our initial application. And our focus was, our objective was to do real world research, addressing behaviors, environment, diagnosis, treatment and care at the intersection between TB and chronic other areas of lung disease, looking particular at air pollution, chronic lung disease, acute lung disease, and smoking, with an intention of generating policy relevant research. So today, for me, one of the things that's been really important is to go back and look at this original aspiration, see did we do what we said we would, and for me the answer is a resounding yes.
Angela, you're muted again.
You're muted again, Angela.
I don't know why it keeps muting me. It seems that you can either hear me or see my slides, but you don't seem to be able to do both. So the approach was intentionally multidisciplinary, and yeah, you've heard from Jan about some of the successes that we've had with that. Intentionally embedding policy engagement. We haven't had time to go into it today, but if you look back over the previous closeout meetings, all the PhDs projects, all the postdoc projects, embedded policy stakeholder analyses, an approach to ensuring that there might be maximal policy impact for the work. And today, indeed, we've had a take-home message, policy focus to all of the presentations. We were intentionally responsive to locally identified priorities, intentionally promoting South-South working. And again, I think you've heard from Asma and Uzo today how successful that has been, especially in the health systems and social science programs. And throughout, both through the policy and through the Moody project, we've embedded learning about this overarching approach. You know, these decisions that we took, you know, we've constantly been reflecting on whether they worked or not. Now,
Angela, I think you're muted again. Sorry.
No, there's something with there's a glitch in the program that's not allowing me to move. I think I just need to click on the screen. So again, for our NIHR colleagues on the call, I think I'm right in saying that ours was one of the biggest consortium. Again, this was intentional. So you've heard from the core projects, the PhD and the postdoc projects, but intentionally we had resources and opportunities for a number of researchers in different countries to take forward activities and research activities, capacity development activities that responded to their priorities. And we've heard the benefit of those from the post-TB lung disease in South Africa, the spirometry training, addressing asthma in West Africa, and building on activities, the ISAC and other activities to improve outcomes in those countries. And I feel that for me, that's a really important take-home message. Understanding that in a program like this, it's important to trust local researchers to identify and deliver research that's going to be of high quality and most importantly, respond to the needs of the research communities, the people and communities on the ground as they emerge over the 4-year period. And one of the changes that we made in response from and this was a decision that was taken in the very first workshop, you'll recall, is in addition to this focus on smoking, there's an important, we recognize the importance of looking at nutrition. And so Rebecca and Zalalam's work has really improved our knowledge about nutrition in the context of that birth cohort. And that to me is another example of one of the good decisions we made in terms of being responsive to emerging priorities. So I think to me that Martina is right now preparing the final report, and there's just too much to put into one presentation. But some of the things that have jumped out for me really in terms of contributions that we've made, take-home messages, things that will be done differently in the countries in which we've been working are a focus on patient perspectives, an increased recognition of the importance of stigma and the need for communication in relation to lung disease. And that seems to me to be a theme that's come right across from Uzo and Elisa's work, but also in other aspects, especially from work some of the partners have come up with and some of the auspices research. Leveraging the TB infrastructure to improve other aspects of lung disease, again, is another cross-cutting take-home message from Brenda's work, from Irene's work, from Uzo's work. TB as a cause of chronic lung disease, I think, you know, we've not heard from Jamila today, but Brian, Jamila, there's been a huge contribution, I think, that IMPALA has made to this emerging issue of post-TB lung disease. And hearing the first symposium on post-TB lung disease to be hosted in Africa, I think I'm right, that's what Brian said. You know, I think it gives, you know, IMPALA as a consortium should be really proud to have contributed to that story. The economic and social costs of lung disease, that's we've known about catastrophic costs of TB. I think Bertie and others did a lot of work, but translating that and taking it forward more generally in relation to lung disease, I think is another really important contribution that IMPALA has made. And recognizing that these costs are modifiable, that there are things that can be done to ameliorate that burden is, for me, another really important contribution that I think IMPALA can be proud of. Another really key piece, and Miriam and Rachel, Uzo, Asma, Eliza, the list is very, very long in terms of taking forward our understanding about health system readiness in our ability to deal with acute and chronic lung disease, models for improvements in delivery, building on the low technology. You know, to me, that's another really important take-home message. Brenda's work on chest X-rays, the opportunities that they provide for identifying other both lung and cardiovascular disease. Wanjiku's work on point of care ultrasound testing in the acute setting. These are all, to me, low-hanging fruit that can readily be translated into interventions, policies, procedures that can have impact in the very, very near future on a large scale. And of course, improved pathways to care, as Eliza was presented so well this morning. And I think the other really important strategy that NIHR took with these units that I feel that we have fulfilled is an approach to capacity strengthening, both through direct investment in training. So we've got our NIHR academicians, you've heard from our PhD students, you've heard from our postdocs. Somebody was asking about the auspices. So the auspices, again, was an intentional approach, which, as Martina has highlighted, is novel. So these are not people who are necessarily funded to have their PhDs or their postdoc training or salaries funded by IMPALA, but we have facilitated access to the IMPALA network, access to mentoring, access to publications, access to a broader collaboration for early career researchers who were completing their PhDs or early in their careers, completing projects, bringing them into the IMPALA family, bringing them in under the auspices of IMPALA as an intentional decision to catalyze their research activity and improve their development, their training and development. And I think you've heard the very positive things that they had to say. And PATSMICOR, I think Kevin, if it would be good to hear from Kevin and Nkobele if they're here, any further reflections on PATSMICOR, which has been the Pan-African Thoracic Society, which has been a really strong partner within IMPALA and a mechanism by which phenomenal research capacity development has been disseminated right across Africa. And in addition to the research training, we've heard from Lindsay about training in relation to clinical provision, spirometry. Wanjiku talked about point of care ultrasound testing. These are things that will make practical, low-tech, practical benefits to patients and the communities that we've been working with. And then, of course, through dissemination, we've funded attendance at conferences, we've funded symposia at those conferences. And IMPALA has been really taken and created opportunities for high-level engagement at the UN, high-level meeting right at the beginning of IMPALA. Elia may want to say something about NIAPACO. This is the network of African parliamentary communities for health. This is a really high-level policy engagement at the Africa regional level, getting the message across about the importance of lung health and the possibility of practicable strategies to address the challenges. And in addition to these very high-level meetings, within each of those projects, there's been ongoing local partnerships, close working with policymakers. I think Brenda's PhD, where she has been working very closely with policymakers, teaching them modelling, working with them to see how this modelling technology can help them in achieving their goals for policy making and improving health provision in their communities. That kind of small scale local trust building activity is incredibly important. And because we have to report these things, you know, there are lots of nice numbers, you know, 68 peer-reviewed papers and counting to date, 37 linked successful grants for a combined total of nearly 40 million. So as far as NIHR is concerned, that's a 5-fold return on your investment. But apart from the numbers, there are these lasting pieces of work. So, for example, the contribution to the Global Asthma Report, which Kevin and others within IMPALA were really central to, you know, with over 100,000 downloads. You know, that's lasting, that's likely to lead to really serious impact. Training, you know, I feel it's important to come back to this. These are skills that, practicable skills that people will be walking away with that will make a difference to human beings in their countries. And you know, Lindsay's piece on that has been really extraordinary. And this is just some of the what people have had to say. It's given us a new direction in practice. I'm considering a career in pulmonary practice after this. You know, bedside sonography. You know, there will be quicker diagnosis. I think outcomes for morbidity and mortality will improve. This is what people who have been touched by IMPALA, people who have benefited from IMPALA, have to say. So the final word, really, from all of us on the directorate, and hopefully Kevin can jump in and add some further words, and Chakaya will be finishing. But prior to them, I really want to say thank you so much for what has been a wonderful partnership from co-investigators, collaborators, early career researchers, stakeholders, patients, students, and of course, thank you to NIHR. That's it. Hopefully you can hear me. Have I been muted for that whole time?
No, Angela, we've heard you, and it was absolutely fantastic the way you put all together, everything together. So thank you very much, Angela. So I don't know whether Elia wants to jump in, and then Chakaya will give us his closing remarks. So thank you, Angela. That was fantastic, really remarkable. Thank you.
Totally my pleasure, and all down to this collaboration.
All right, thank you. Yeah, Martina, I would like to say a few words. As you've said, Angela has really brought it all together. And but I want to say one or two things really from my own perspective on what we think are really the key sort of achievements of the program as well. And I think as we do that, the first thing is basically to ask the question, what did we seek to achieve? And our strategic aim was to improve the health of children and adults in Africa through multidisciplinary applied research on lung health and TB. And so if you really say, if you break that down to say, what were the things? We really talked about generating new evidence, and Angela has outlined that evidence that the group has brought together. There was an issue about building capacity in knowledge generation and translation among researchers across the continent at different levels. And I think Angela has also talked there about the PhDs, the postdocs, but also many other early career researchers who benefited from the capacity building activities, hands-on, some through defined workshops and so on. So a lot of progress on that. The program's initial decision to make sure that the PhDs and the postdocs get training in promoting evidence uptake, in planning for use, making sure that the evidence that is going to be generated will have input from decision makers, but also that it will really stand a very good chance that it will end up on the table of decision makers for them to inform their decisions. Was very, very central, and I think it really helped to have the program focused a lot on evidence uptake and improving programs and policies. That was the third arm, actually. That was promoting the uptake itself, building internal capacity, but also promoting the uptake in decision making at global, regional, and national levels. And I think one critical thing is what Angela was also talking about: the community of practice. Forging and strengthening the community of practice in all these countries where the work was done in Africa but also among other players outside Africa who really came together to what I called at the beginning when we had this meeting in Blantyre, that this was like a movement. It went beyond being a research consortia, but it was like a movement of people who came together to enhance visibility of TB and lung health, and try to generate actionable interest among policymakers on how to address these issues. So a lot of what really we've done has already been said in terms of what we've produced as a program. But just to note really at the policy level, just to highlight a couple of things that Angela mentioned, but maybe didn't go into that much detail. At global level, of course, she talked about the work we did at the high-level meeting at the UN, as well as the engagements with the union and in many other meetings. But at regional level, I think one of the key things we've done is really to bring parliamentarians, to try to get parliamentarians to be champions on TB and lung health. And we use this NEAPACO, the network of African Parliamentary Committees for Health, where we, in November last year, we presented evidence from the consortium to members from 25 African countries, and a number of them, a handful of them, have shown more interest, where now we are following up to see how we can strengthen them to engage better with ministries of health, but also as representatives of people to promote, to actually be ambassadors for TB and lung health services and so on in their countries. So that has been done very well. COVID prevented us from doing a number of other things. We mapped out the regional economic blocks in Africa, in West Africa, Central, East, as well as Southern Africa. And they are still interested in looking at the evidence that we have, and we are following up. The great thing is that under the NIHR arrangement, we still have the following 24 months when we can continue disseminating the findings. At national level, we've done a lot as well. I think the most visible one is what has happened in Kenya with a program that came out of the IMPALA on post-TB lung disease, PTLD. And this program really got the Minister of Health in Kenya to prioritize PTLD as a critical health issue. They formed a task force just to focus on how to make PTLD a critical health issue in the Ministry of Health. And they developed guidelines for how, to start getting the ministry react and provide services in this area. So this has gone very well. We even got them to consider including funding of PTLD in their global fund application in Kenya. We've engaged with Ministry of Health in Malawi, who now are having a broader sort of engagement with the Malawi Liverpool Wellcome Trust, AFIDEP, and the other partners working in Malawi, so that we engage with them on various issues. There's a lot of research that has been done in Malawi on TB and lung health, and we want to make sure that the TB program there is engaging in a more structured way with the research that is happening. And they have shown interest. They have even said we develop an MOU with them. We've just heard about what happened in Sudan as well, where now the case management protocols that have been developed under IMPALA have been extended to 5 states, and there's a plan to extend them to nationally by 2024. So there's a lot of work that has been happened in Uganda, in Tanzania as well, where we all engaged with the TB programs there, whether it was on World TB Day and so on. So we feel that at national level, there's a lot of potential for more to be done. And as we look forward in terms of the roadmap going forward, as I said earlier, we are quite pleased that NIHR still allows us, and there's some resources there for us to continue the disseminations. Of course, the big challenge on a program like ourselves is that this doesn't cover personnel time. But the good thing is that we now have the evidence on the table, all the evidence that we need, and we've established these connections. And we believe that over the next 2 years, we are really going to continue disseminating these findings, leveraging on other programs that we have in our institutions, on NIAPACO, on the regional economic blocks, but also in the countries where we are. Many projects, when they come to an end like this, it's like people stop working, going forward. But I think at AFIDEP, we really believe that promoting uptake of evidence in decision making is a long-term venture. It's actually, this is the time when the project is ending. That's the time when, you know, we have the greatest promise of having of actually achieving the impact that we sought out to achieve. So we are excited, and all our institutions have talked about ways in which we will continue to use the evidence that has been generated, the capacity that has been generated, in order to make sure that ultimately this program will have really made a big difference in improving if we go back to that objective, in really improving the health of children and adults in Africa through multidisciplinary applied health research on lung health and TB. I myself haven't been in a program that has been so expansive, that has been so interesting, and as we are giving thanks to everybody, I would like also to thank the team at LSTM for the flat leadership, where everybody had a voice in the team. Not only the leadership in terms of Betty and Chakaya and Kevin and Angela, but also Martina for the way you coordinated. It was really a very, very expansive network with so many players, but we all work together with the aim of really generating and promoting uptake of evidence to make lives better as far as addressing the lung health and TB challenges that Africa is facing. So thanks, I'll leave it at there. I'm really leaving this program with a lot of optimism that there's more impact that we've generated. But so far already, just look at the capacity, the PhDs, the postdocs, other early career researchers, the evidence uptake capacity building that we've done, and the evidence we've generated. I feel that this has really been a wonderful, wonderful program. Thank you.
Oh, thank you,
so
Elia.
much, Elia.
I feel I want to clap my hands. Thank
I think
you
we
so
can
much.
all clap, actually. We just do one big round of applause. That was wonderful. Really good.
Thank you. So I think I'll hand over now to our great co-deputy director, Chakaya, for the final remarks and look into the future. Chakaya, the floor is yours. Thank you.
Thank you so much, Martina, and thank you, Angela, Elia, and everyone who's spoken before me. I think in terms of the meat of the project and what we've done over the last several years, that's been beautifully highlighted by both Angela and Elia, and I don't want to spend time dwelling on the brilliant speeches that have already been given. But I have a few key things that I think for me are key for us to take home with us as we get close to the end of this wonderful initiative. First, I think we came in here, some of us did not know each other, and we've become great colleagues and great friends in advancing the cause of lung health programs in the African continent. And it's my wish and my hope that going into the future, we will continue to remain connected. I am imagining that we could, in fact, we will see the growth of a network of African researchers, of course, working in collaboration with our colleagues from the North, that would really move the needle in terms of lung health research in the African continent. So I really hope that we will find a mechanism and some way of remaining linked and networked as we move ahead, forging forward with lung health research in our continent. I think there's a lot of work that needs to be done. As you all know, when you start doing research, you discover things and you are glad because you have great evidence that have come to you in terms of how things need to be done. But as you do that research, you discover that there are still many things that are not known. So we need going forward to continue doing robust research, especially in the area of refining and testing innovations and interventions that would improve the outcomes of the millions of people who suffer from chronic respiratory disease in the African continent. And I think it's really important that going forward, we do not drop the ball in terms of the advocacy efforts that need to happen at our own local level, at a regional level, and at the global level to advance lung health research. So yes, I think we've just finished a great piece of work, or we seem to be coming to the end of a great piece of work, but that's just the beginning of yet a lot more work that needs to be done to improve health outcomes for lung health in our continent. And really for the PhDs and the postdocs, I hope IMPALA has given you the opportunity to engage with each other, to engage with respiratory health, and I'm hoping that as you advance your careers, you will in fact remain engaged in lung health and in respiratory health going forward. I don't have much to say at this moment, just to say a big thank you to all of you, and I'm really looking forward to some form of engagement of this community of researchers that would not just remain linked with ourselves, but hopefully we can bring other key players into the mix as we move forward to support the development of programs for chronic respiratory disease in the African continent. Thank you very much all, and I look forward to continued engagement with all of you as we move forward. Many, many thanks.
Thanks so much, Takaya.
Thank you, Takaya, and thank you everyone, to all the speakers, the students, our partners, our directors, and our fantastic admin team in LSTM and in country that helped us throughout these 4.5 years. Thank you to NIHR, thank you to all our researchers. And the meeting has now ended, so we thank you for participating. And we'll be sharing the recording and all the presentations. Angela, I would like you to ask you to please send me the presentation so we can share it widely. And the only thing I'm going to ask everyone, it's a bit cheesy, but can I ask everyone to turn on their camera for a second so I can take a quick screenshot, please?
I think that's a brilliant idea, Martina. You know, while everybody's doing that, you know, I just want to add my thanks to you all and to the admin team. We call them the Fab Four, who have been with us from day one, and we couldn't have done any of this without them. So thank you all.
Great. Oh, thank you. I can see everyone. That's brilliant. Oh, wonderful. You look so beautiful. Thank you, everyone. Thank you. Oh.
Thank you. Thank you so much.
Wonderful.
Bye-bye.
Thank you.
Bye. Take care, everyone. Stay
Bye.
safe.
It's lovely to see some faces I haven't seen for years. Brian, Lucky.
Bye-bye.
Thank you.
Bye.
Good to see you.
It's great to
Bye,
see you. It
guys.
really is.
Thank you.
Are
Bye,
always looking
everyone.
lovely.
Bye-bye.
Bye.
Bye.
Congratulations, everyone.
Bye.
Fantastic.
Thanks.
effort.
Thanks, Patrick. And you're very, very, very welcome. Thank you for having stayed with us. In fact, Patrick, while you're there, is there anything that you wanted to add? Or anything you wanted to ask?
No, well, I mean, that's so much information and across such a huge range of themes and some fantastic presentations. Apologies, I was kind of multitasking. I was dipping in and out, and there was another Zoom thing going on behind me, and cats and teenagers rushing around too. But so I'm sorry I wasn't able to give it my undivided attention. I gather Bertie was in the funding committee, and that's probably why most of my colleagues weren't there. So I was like the token representative, but I am actually leading on the policy engagement side of things. So I'd be very keen to catch up with you.
Super. Wait, have you met with Elia already?
With
Elia. So Patrick,
no,
so just to
yet.
do some introductions. So Elia Zulu, who is a director of AFIDEP and has led our policy engagement piece. This is Patrick Wilson, who's the global director for.
No, not a director. No, just I've got a weird title. Head of Global Health Communications and Engagement. So that's
NIHR.
With NIHR across the board, but specifically on global health. And we work quite closely with, obviously, Giovanni Medici, and she's done some blogging and op-ed pieces for us, and we want to do more of that right now because, of course, we're waiting on the funding settlement from the UK government, and there's a lot of politics involved. Obviously, there's the sort of the grand politics around the cabinet table, and then there's the civil service jockeying between FCDO and CHSC and BASE, the others, and of course, there's always sort of departmental politics. So I think at the moment we're still, we know that it's been pushed back. There was a consultation on the international development strategy that I hope some of you had the opportunity to take part in. It was a bit rushed because they were trying to actually finish the strategy